Hi, my name is Jay Patel, and today I'll be answering some of the 2 out of 3 of the Unit 4 pathway questions. So for the first question, I chose case study 1, and in this case, it reads, a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The question asks which diagnostic would be best to distinguish between a urea cycle disorder and a disorder in beta oxidation. And then it says, please discuss your rationale for this choice. The options are as follows: A, blood glucose, B, urinary acids, C, serum fatty acids, and D, plasma glutamine. When looking at the case, they also give a couple other details, which I'll read right now. So it says a full blood workup was ordered for this female, and the data is presented below. So within the data, it states that the initial blood ammonia level was elevated at 314, where the normal range is around 17 to 80, and it rapidly rose to about 600. The urine uric acid level was marked at an elevated level of 473, where the normal levels are 0 to 3, and the plasma citrulline level was normal at about 10, and normal is around 12 to 55, so that's fine. So the first question asks which diagnostic would be best to distinguish between a urea cycle disorder and disorder in beta oxidation. So when analyzing the multiple choice question, you want to take each choice one by one and rule out any choices that you might not think is the correct answer. So when looking at the options, there's a lot of things you can tell from each choice. So in this case, I use material that I learned within the lecture PowerPoints and just outside research that I did. So we know that glutamine is considered a non-essential and non-toxic amino acid. So this acid, glutamine, it takes part in detoxification functions in the body. And additionally, glutamine, it's also capable of the transportation of ammonia within the body. So when examining the urea cycle disorder, we're able to see that the rise of free ammonia also contributes and leads to the elevation of plasma glutamine levels. So despite the glutamine levels being normal in beta oxidation defects, the conclusion of the data leads us to believe that the case faced is an example of a type of deficiency. This deficiency is known as ornithine transcarbamylase deficiency, and it's abbreviated with OTC in this case. So this deficiency is distinguishable via severe disease within affected boys who have very high serum ammonia levels. So in contrast, in girls that are affected with the disease, it causes a mutation within one of the X chromosomes. So this can also lead to a condition known as hyperammonemia, and other side effects may include a strong feeling of laziness and lack of energy, which it speaks about in the prompt, which is also known as lethargy. So to answer the question, which diagnostic would be best to distinguish between a urea cycle disorder and a disorder in beta oxidation, the best thing to use would be plasma glutamine. So the next part of the question asks, in this patient where uric acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that's least likely to be impaired. So when you look at the data, you can tell there's several things going on. So you look at where the uric acid levels are elevated. So more specifically, there's a certain enzyme that's most likely deficient and another that's least likely to be impaired. So in concluding from the data, OTC deficiency, this leads to carbamyl phosphate, which is able to be gathered within the mitochondria. This material secretes itself into the cytoplasm. and then it's sent to undergo a process known as pyrimidine synthesis. So this results in increased concentrations of orotic acid, which is found within the urine. So because of this, the amount of orotic acid is significantly higher, and it helps us tell the difference between carbamyl phosphatase synthase and ornithine transcarbamylase deficiency. So in conclusion, to answer the question, OTC is found to be the most likely deficient enzyme, and the enzyme least likely to be impaired within the body is found to be carbamyl phosphatase synthase. So the second question I chose was case 2. So case 2 reads, a 4-day-old infant, patient A, is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth, which was vaginal delivery, were normal. So results from the newborn screening demonstrated a phenylalanine, or abbreviated PHE, level of 6.6 micrograms deciliter, where the normal range is 1 to 2. So a presumptive diagnosis of phenylketonuria was made, which is abbreviated PKU, and additional samples were obtained for further analysis. So the parents deny a family history of PKU. So the first question asks, as a consequence of this presentation, which amino acid may become essential? So we learned that PKU is congenital and is a congenital slowing of the metabolism. So this is caused because the enzyme phenylalanine hydroxylase is absent within the body. So this in turn causes the body to be unable to metabolize the amino acid tyrosine from phenylalanine. So therefore, amino acid that can be found as essential is phenylalanine, because if there's a lack of it, this enzyme that I spoke about earlier, phenylalanine hydroxylase, the overproduction of the amino acid can actually cause damage to the central nervous system and cause brain damage in the body. So PHE dietary restriction therapy was initiated at 14 days of age with good response of plasma phenylalanine levels that dropped to within normal ranges. So the question asks, what are the potential causes of the presentation of PKU? There are many potential causes regarding the presentation of PKU, but this condition is an autosomal recessive genetic disorder. It's actually transferred by means of inheritance from parents who are carriers of the disorder. The treatment of the condition includes giving the body an amount of phenylalanine that is essential for growth and tissue repair, but you do not want to overgive this amino acid to the body itself. The only way this can be properly done in a healthy manner is by undergoing a protein diet in the body and watching what you eat. So as the amino acid is reduced in the body, there should only be a tolerable amount in the body itself. Another infant, patient B, is also being evaluated for suspected PKU. BH4 loading tests are performed on both patients, and the results are presented below. BH4 loading tests, tablets of synthetic cofactor are dissolved in 20 milliliters of water in dim light and administered to the patients at least 30 minutes before a meal. They then begin to draw the blood before and 4 to 8 hours after the BH4 loading, and they calculated the PHE levels. So the final question asks, when you look at the graph that's given at the bottom of the case study, it says, how would you summarize the results for this test for patient A and patient B? BH4, it's a coenzyme, which is integral for the conversion process of changing phenylalanine into tyrosine. This is done by utilizing an enzyme called phenylalanine hydroxylase, which we spoke about earlier. It's abbreviated PAH. The activity of the enzyme is deficient in patients who suffer from PKU. So when you look at patient 1, you can see that he has elevated levels of phenylalanine as time passes. This occurs during the administration of BH4. So as a result, this may mean that metabolizing the amino acid in order to convert it into tyrosine may not be possible in patient 1. However, when you look at the data for patient 2, phenylalanine is being metabolized and converted into tyrosine. So as you look at the data, it seems that it's possible that metabolism and conversion is actually occurring for patient 2, while in contrast, it's not happening for patient 1. So in conclusion, the suspicion regarding PKU is found to be inaccurate because in one patient, it's just not happening. In patient 2, it seems to be doing the conversion properly. So that's the answer to that question.